Okay, so let's get started here. Good afternoon, and thank you all for joining us. And a special thank you to Dr. Eric Lullove for being here today to present on clinical perspective, my experience using and billing for the MolecuLight wound imaging procedure. Now, after his presentation, there will be a short Q&A. So please go ahead and find your chat icon and put any questions that you may have for Dr. Lullove into the chat for this call. We'll try and get through as many as we can. And I'll now turn this over to Dr. Lullove, who is Chief Medical Officer, West Boca Center for Wound Healing down in Coconut Creek, Florida. Thank you so much, Dr. Lullove, for being with us today.
Monique, thank you so much for having me, and good afternoon, everybody. Thank you for joining us on this wonderful Friday afternoon in early March. So I am the medical director at the West Boca Center for Wound Healing in Coconut Creek, Florida. I've been using the MolecuLight for over a year now. I started in February of 2020. And you can see my disclosures above and the indications for use for the MolecuLight. So one of the really nice things about this device is, and I want to make it very clear, this is not a camera, okay? Yes, there is a camera, but it's not a camera for purposes of what we're doing, okay? This is a imaging device. This allows you to take an image, both standard static imaging as well as fluorescent imaging, to detect bacteria at a level of 10 to the fourth, which will basically tell you where you have areas of increased bioburden and bacteria in the wound that you are going to need to make your debridement more accurate. Okay, so the typical process is to take your static image and then take your fluorescent image, and then use those two pieces of information to formulate your treatment plan and your treatment for that patient. Next slide. So here's one of my patients that I have been fighting with for a while. This patient underwent a transmetatarsal amputation and wound up with a lateral wound with a flap dehiscence. So what you're seeing here in these two different images is that in visit 2 on the left, you could see the standard image, the static, where he measured 36.34 square centimeters. And then you could see the fluorescent imaging right next to it. So the imaging then directed me to indicate an area where I needed to be a little bit more accurate with my surgical debridement, perform the treatment for the day, brought the patient back on his next visit, which was, I believe in this case, 3 or 4 days later. And you can see the immediate drop in the wound diameter, as well as in the fluorescent imaging. You can see that there's less fluorescence in the center of the wound, but he still had bacterial imaging that was fluorescing both at the 11 o'clock area, kind of around the 4 or 5 o'clock area, and as well as down by the 7 o'clock area. So you could see where targeted, accurate debridement technique based on the information that you get from the imaging device of the MolecuLight helps make your treatment more accurate. Next slide. So these are the procedure codes that are currently available for using the MolecuLight, both in ambulatory surgery center, hospital outpatient department, as well as physician office and non-physician office. The APC code for hospital is the 5722. The CPT coding for ASC and physician offices is the 0598T and the 0599T. Now, the reason why you're seeing some asterisks over by carrier pricing under physician office payment is that as of right now, what I am able to tell you is that certain contractor carriers within the Medicare system are reimbursing this procedure and this device, but at different levels. So it's not uniform across the country. And this is definitely something that MolecuLight is working on with all the contractors to unify the pricing and the coding. The APC payment is standardized at $264.45 for 2021, and 134.32 in the ASC environment. The other thing I need to mention is that when you are using the 0599T for additional units and additional wounds, that does seem to have some issues currently within the coding structure within Medicare, but you still report your coding appropriately for the work that you do. So the sites of service are pretty wide. This is because this device is portable, it literally can fit into your lab jacket. It can go into your backpack. It can go into a carry-on. It literally can be used at any facility site of service, from telehealth to office to nursing facilities and hospice care. Depending on the area and the imaging area that you're in, if you have a room that has a lot of bright light windows, like a hospital room, you may need to have the dark drape with you to encase the device in the dark drape so that you can do your imaging. I'm fairly fortunate that my clinic offices are inside my clinic and they're walled in, so there's no direct sunlight. So I have very little need for a dark drape. But when I am in the hospital setting and I have a patient's window that I have to deal with and I can't get a complete dark environment, this is where the dark drape comes into play. Or if you have doing this in a patient's home and there's not a lot and there's too much light, that's what the dark drape is for. Continue. Again, like I said, so you're going to use the 0598T for your first anatomic site. So it does not matter how many wounds are on that first anatomic site. You're going to build the 0598T for your first anatomic location, and then use the 0599T for your second and then subsequent anatomic locations. And the 0598T, like I said before, maps to the APC 5722 for outpatient hospital setting. So this is not the guideline per MolecuLight. This is my own performance procedure guideline. My reasoning is that in the first 4 weeks of treatment, the wound is most likely chronic in nature. It's got loads of cytokines, there's increased inflammatory mediators, there's increased bioburden. This is the time when you have to get the wound under control. If you do not aggressively deal with the wound in the first 4 weeks, you're going to lose track and you're going to lose time and you're going to lose traction on your patient. So I typically, in the first 4 weeks, it may be 3 weeks, it might be 4 weeks, depending on the wound and how it's responding. But typically I will do the MolecuLight procedure and use the device twice a week to image the wounds. After 4 weeks, once I've gotten more control and things are more consistent, then I'm down to once a week or even less as needed. But the idea is to get yourself on a trajectory where you control what's going on in the wound bed and the wound bed's not controlling what you're doing. The whole idea is to flip the inflammatory cascade and use the device and use the fluorescent imaging as a technique and a tool to help guide what you do. So again, at the end of the day, this all comes down to documentation. And so these are some examples of how I document within my charting system. And so you want to name the procedure. And I do this in the procedure component of my chart record. It doesn't go under X-ray. It doesn't go under imaging. This is a separate procedure. This goes in the procedure component of your chart. So I basically will say non-contact real-time fluorescent imaging for bacterial presence of X extremity or X location. If you use the dark drape, you need to mention the use of the dark drape. You must have the anatomic site, wound size, and immediate appearances. You still do your regular documentation that you're going to do. You're still going to describe the wound as you see it with the naked eye. But you also want to use the language specifically in the national coverage policies for presence of infection, pathogenic bacteria, biofilm. And you also want to make sure that you are documenting the absence or presence of the red color, the cyan fluorescence, or maroon. Maroon would be that there isn't any fluorescence and the wound is a healthy bleeding wound bed. And then you want to make sure you have your medical decision-making in your chart record on what you did because of the use of the device. Again, in summary, the MolecuLight can support and visualize with part of the imaging process, bacterial burdens elevated greater than 10 to the fourth power. It gives you a digital wound measurement, both in length, in width, and in depth. It's a safe technology that you can use in any place of service, and it has the reimbursement pathway as we discussed earlier. And again, your frequency of imaging is based on your medical necessity and your wound status, and it all comes down to your documentation and medical prudence as far as use and accuracy. So Monique, thank you very much. That was very fun to do for me. Thank you.
Thanks so much, Dr. Lullove. Okay, I'm just bringing up our chat box. So if anyone has any questions, please put them into the chat. And we have one here. Dr. Lullove, can you use this on all types of wounds? Is this limited to any specific wound type?
No, there is no limitation on the wound type because of the way that the device is used. It's imaging per anatomic area. So if there is a wound in any anatomic area within your standard scope of practice, then you can certainly use the device per your medical necessity on any location, any wound type.
And I know that you've been using the device. I know you used it pre the COVID pandemic and then during the COVID pandemic. Can you comment on how patients engaged with the device during COVID, or how you used it during COVID, during that infection wave?
Sure. So thankfully, hopefully everybody has gotten through the pandemic with minimal scarring, and hopefully the listeners and people tuning in here have not had any tragedy within their own families. And I wish everybody to get vaccinated if they are not already, but if they need to, get it. Getting back to the original question, Monique, as far as how I utilized this during the pandemic it was a way to keep patients interactively active in their own care, because they could come in, they could see the wound being reduced, they could see the imaging, and I made sure that I showed them the imaging after every photo. After every image that was captured on the device, I showed it to them. And they could see from week to week the progression and how things were going, but it also allowed them to feel kind of normalized in what we were going through, that they felt the ability that they were safe enough to come to the clinic, have their wound taken care of, have all this imaging done, the care, the guidance, to have some level of normalcy. And I was never one to be big on telemedicine for wound care because of, as a surgeon, you want to get your hands dirty. I just didn't think it was appropriate to do a lot of wound care via telemedicine. I need to see the wounds. So this was a way for me to do it effectively with safety, but also not specifically kind of hiding in a bunker. I know that there were areas of the country that, and parts of the world, that just didn't have a choice. And if all you had was telemedicine, this was one of those things where if the nursing agency, the home health agency had this device and you could telemedicine with the nurse with the device, it allowed you to at least see the fluorescent imaging to make clinical decisions live and in real time. So that's also one of the advantages of this device, still during a pandemic when you have to do a telemedicine wound care visit, is if the nursing agency can do the device live at the patient's home via telemedicine, you have that ability to do that. So it was one of these ways where I made a decision to bring the patients into the clinic and keep it pretty safe. So.
Thanks so much. I'm sure that's very helpful to the listeners. We do have a specific question about the billing, and it is: do you charge both a provider charge and an APC charge, or is it either or?
So again, it's based on your place of service. So because my facility is place of service 11, we just bill our physician office site service codes, and the APC code is left to the outpatient facility. On the outpatient facility side, the facility will bill the APC code, and depending on the physicians, whether they're a contractor or employed, then that is up to the facility's billing department to determine separate CPT RVU reimbursement on the physician side. So in an inpatient facility, this is all under DRG. There's no separate billing under the DRG for use of the device, but it has to be hospital outpatient.
But the CPT codes could be billed in the
Yes.
inpatient setting.
They could be.
Okay.
On the physician side, if I bring the device in and I do it, there's the physician component payment.
Okay. All right. Well, believe it or not, we've gone through 15 minutes. This happened very quickly.
That's too short.
It was so short. It was
Sure, we
so
need to do
short.
double sessions.
So I want to thank everyone for attending. I want to thank Dr. Lullove especially, and just remind everyone that they can visit the MolecuLight virtual booth. It's in the exhibit area here to get lots of resources, use the chat to ask any questions about the device. There's reimbursement information there as well. And you could also arrange to book a demo of the MolecuLight device at your facility or virtually, which is a way that we've adapted to the ever-changing times. Okay, so thank you so much, Dr. Lullove.
Thank you, Monique. And I see my friend Dr. Yoza there in freezing Phoenix. So
All right, thanks everyone.
Thank you so
Have a great
much.
day.
Okay. Bye-bye, everybody. Thank you. Have a great weekend.